Hello, everyone. It's wonderful to see you all today. We are so excited to close out this year's Women's History Month together. Thank you for joining us. I'm Dr. Tony Stern, and I am an associate professor within the Department of Obstetrics, Gynecology, and Reproductive Science. Within the department, I serve as the Mount Sinai Health System Vice Chair for Quality, Diversity, Equity, and Inclusion, and as Chief Patient Experience Officer. I also am the Senior Associate Dean for Gender Equity and Clinical Affairs on the Office of Gender Equity team, and I'm so honored to be with you today. Thank you for taking the time to join this very special Women's History Month webinar this afternoon that's hosted by our Office of Gender Equity in Science and Medicine. The Office of Gender Equity in Science and Medicine works to enhance our systems and climate so that all faculty and trainees are valued and have the opportunity to succeed, regardless of their gender expression or their gender identity. This year, our Office of Gender Equity commemorates and celebrates the very vital role of women throughout history by highlighting the trailblazing women who have made Mount Sinai history. We encourage you all to visit our new website in honor of Women's History Month, and it honors the women and allies who've worked towards making our institution a very equitable place for everyone, regardless of their gender expression, or gender identity. We have dropped the link in the chat, and we encourage you all to explore and stay connected to our office. As part of our many initiatives for gender equity, last year we launched the Amplifying Equity Speaker Series. And this series features esteemed colleagues in the work towards advancing gender equity in our institution and beyond. We are so excited to continue our speaker series today and bring you a very special Women's History Month presentation by Dr. Jenna Tonn titled Histories of Women in STEM, Headwinds and Signs of Change. During the presentation, please feel free to ask questions, you can place them in the chat or unmute, and we will address during the Q&A session afterwards. We will also be recording the session and sharing with all participants. It is now my honor to introduce Dr. Jenna Tonn. Dr. Tonn is a historian of science and technology at Boston College. Her research focuses on the social and cultural history of technical knowledge, with a special interest in women and gender in STEM fields. Currently, she's working on books, Boys in the Lab, Masculinity and the Rise of the American Life Science, about the relationship between manliness, experimental biology, and feelings of belonging in modern science. Her next project is about the history of radical feminist biology, and her research specialties include histories of women, gender, and sexuality, and modern science and technology, and the interplay between engineers and engineering practices and the infrastructure of everyday life. It's important for her to evaluate the relationship between design, technology, and justice. She received her PhD from Harvard University and her BA and MA from Stanford University. Thank you for joining us today. Dr. Tonn, I turn it over to you.
Thank you so much, Dr. Stern, for that wonderful introduction. It's great to be here with all of you. Let me just share my screen so I can put some slides up. Can everyone see that? Some images? Okay, great. Yeah, so feel free to interrupt me if you have any questions. I'm so happy to be here speaking with you all. Thanks, Danielle. On the second to last day of Women's History Month. As Sandra suggested, it's a busy month for me, and I love it. I like to think about the history of women and gender in science and medicine. So what I thought I would do today is talk a little bit about the history of women in science and medicine from the perspective of representation, and then tie that to histories of medical and scientific knowledge about the female body, and make an argument for you that it's really important to think about representation for its own sake, but also because of the translational effects that representation has for the production of equitable, sort of important knowledge about all different kinds of bodies, especially female bodies, because of the history of sort of long-term discrimination against women. And so what I thought I'd do is sort of start here to give you a sense of the relationship between cultural expectations of gender biological or medical understandings of sex difference, and how there's almost like a feedback or reinforcement mechanism that we're trying to manage and deal with in the 21st century. So this image on your left, I don't know if you can see my arrow here, so of X and Y chromosomes. The X chromosome is stained pink and the Y chromosome is stained blue. So for those of you who have been to medical school, which is I think almost many, or if not all of you, I think you know that sort of chromosomally both males and females have X chromosomes. So here we have this sort of beginning of layering of biological knowledge about sex difference with cultural stereotypes about boys and girls. So baby girls are sort of dressed in pink and baby boys are dressed in blue. And so this is like this relationship that I'm interested in as a historian, of trying to understand historical ties between gender expectations and gender stereotypes and biological or medical knowledge. You get this amplified in this like little sort of cartoon in the middle here. So this is X and Y chromosomes, what to bring on vacation. You have Jill, which is the X chromosome on the left. Jill's going on vacation, bringing like everything in her house. This is like leans into the gender stereotypes of packing on vacation. And Derek, presumably her partner, brings like underwear, a passport, and cash for 2 people. So here again, we have these like sort of cultural reinforcement of gender stereotypes between men and women, this old idea of men are from Mars and women are from Venus, and how do we understand this relationship of human people layered onto chromosomal or biological objects. And then one of the things that you see, and maybe you have experienced in teaching your own students, is how this leads into gender expectations about facility and STEM subjects. So here I'm thinking about science, technology, engineering, mathematics, and medicine. So this idea that there are sex differences that relate to these cultural stereotypes that can then predict facility in technical fields. So there's this cartoon from XKCD. If on the left here, if a dude is bad at math, it's just, oh, you're bad at math. But if a woman happens to be bad at math, it's women in general have like problems with mathematical reasoning. So today, what I want to do is start to unpack some of these relationships through the lens of history. I will discuss this in 3 different parts. The first is histories of representation. So where do we find women in the history of science and medicine? How do we think about the problem of professionalization, which I think really comes to structure how professionals in science and medicine think about their careers today? Second, I want to tie this to this knowledge question, which I think is so important. So the production of knowledge about gendered bodies. And then third, hopefully we'll have some time to think about the future, looking towards what can we change? What are some possibilities for making a difference amidst all the challenges that we have and that we are facing today? So I'm going to start by discussing this question of representation. This really comes from my own research, which is about the history of masculinity and manhood in zoology or animal biology in the 19th century. And I often show this picture to my students and I'm like, someone tell me, it's like, what is going on here? And my students often say things like they have interesting beards and mustaches and they wear suits, but this really is sort of the sort of stereotypical image of doing basic biological research in the late 19th century. It's largely white, it's completely male dominated, and this structures the institution of science itself. It structures how people enter into the institution. Expectations of manhood are required to apply for graduate training in the sciences, and of course structures that is knowledge that is produced. So many of these men here studied with this particular zoologist named, let's see if I can get my mouse over there. No, well, he's in the middle. His name is Edward Lawrence Mark. He trained multiple generations of scientists who went on to write the textbooks about human biology, about sort of basic biological knowledge that were then used to train generations of medical practitioners. So the kind of manhood that was understood in this laboratory had diffuse effects later on for men and women who were pursuing careers in science and medicine. One of the points that Sandra made when we were sort of talking a little bit before we started is this question of where you find women in the history of these kinds of fields. And so there is a myth that there were no women in science or no women in medicine before the 19th century. And Margaret Rossiter, who's written a number of books related to women scientists in America, talks about this as the myth of invisible women in STEM. This idea that we don't see them sort of, in publications. We don't necessarily see them in lists of faculty members at medical institutions in the 19th and early 20th century, but that doesn't mean they don't exist. And she says, when we're looking for women in these histories, we have to look for women in two different kinds of registers. One is women who have been territorially segregated in the world of science and medicine. So this is looking for women in, for example, women's colleges. So women who are scientists and women who are medical practitioners were often hired to teach and do research in women's colleges. So they're sort of segregated apart from mainstream male-dominated science and medicine. And they're often segregated in what she calls gender-appropriate fields. So say you're a woman and you're really interested in chemistry, the 1850s, 1860s, you're going to be pushed towards home economics or public health as opposed to more academic forms of chemistry. So we can find women in these territorial spaces. We can also find women in male-dominated fields of science and medicine in what she calls hierarchical segregation. So this is, not at the top. We're not going to find them as named chairs or professors. We're going to find them in these low-paying, low-status jobs. And this image, which comes from an article I wrote and also the book that I'm writing, really illustrates that. So this is an image of the Museum of Comparative Zoology, a site of natural history knowledge making in the 19th century. In the back corner, who we have is Herman Hagen. He was the main bug entomologist expert at the time. He was the person who was listed on all publications and paid for doing this sort of bug-related work. But who you see in the foreground is a woman specimen collector who's sort of hunched over. She's actually cleaning and identifying beetles for Herman Hagen to write about. And this really illustrates this form of hierarchical segregation. These women were present and doing this kind of work in museums, in hospitals, and all sorts of medical and scientific institutions, but they tend to be at the background or in the shadows. This relates to something that Margaret Rossiter has talked about, which I think is so important for thinking about the history of women in science and also our future of women in professional fields. And it's something that she calls the restrictive logic of precedent. It's this idea that because we haven't had women in, say, leadership roles, there's no precedent for then inviting women to take on those leadership roles. So this no precedent logic is very potent in the 19th century. And I think you can still see traces of it today. So we haven't had a woman CEO in this particular biotech firm. How can we, imagine what that might look like? So this restrictive logic is relatively powerful and potent. I work in particular when we think about women in science at this site. This is the Radcliffe Zoological Laboratory. Radcliffe College was an all-women's college associated with Harvard College during the late 19th and early 20th century. Unlike other women's colleges, it didn't hire its own faculty. It was sort of an adjunct institution to Harvard, which meant that women who were trained at Radcliffe actually couldn't get jobs to teach their own sort of students. Instead, Harvard instructors taught their courses to Harvard men and then went and walked across the yard and taught them to Radcliffe women. And I think what this really illustrates is the marginal place of women in science at the time. So just to give you a sense of their access to these kinds of facilities. So this is the Radcliffe Zoological Laboratory. This is the 5th floor map you can see on the right hand of the screen. It illustrates all the different facilities. And one of the things I became interested in when I was doing this work was like, okay, well, where did women pursue their zoological knowledge, which was necessary for them to go on to medical school? And it turns out it's in this tiny room, room number 16. It was an old storage room that was converted into the women's laboratory. If, say, you wanted to be a medical practitioner at this time period, you needed an undergraduate science degree. So just imagine, access to this kind of space is really important to that knowledge. And I think this just speaks volumes to the gender politics of how to educate women in science during this time period. Sure, we'll educate them, but we'll give them a room that's completely inadequate, that's actually embedded in a tacitly gendered campus space. So we can think about questions of access and feeling sort of comfortable doing work in these spaces more broadly. So one of the things that I found when I was doing this work is Lucy Sprague, whose name is at the top in green. She was a Radcliffe student around 1900. She actually became an educational revolutionary later on in the 20th century. But she came to campus and was really excited about being a zoologist. She boarded in Quincy House, so she lived at this #1 figure with a group of family friends. And on her first day here, she writes in her diary about the dean of Radcliffe College came and paid her a visit and said, do whatever you want, but you can't walk through the Harvard yard because because it's just for men. And she was like, what? Harvard Yard is the most efficient way I can get from my house, which is here on number 1, to Radcliffe College, which is to your left on number 2, where she was doing her work, to the Radcliffe Zoological Laboratory, which is up north on number 3. So this is how I like to sort of think about this question of access for women in science and women in medicine at this time, especially in coeducational or coeducational adjacent spaces in the late 19th century. You have not only a lack of facilities, but you have this sort of gendered question being embedded in a hostile or slightly inaccessible campus life. And she writes in her diary being really upset about this. And she's like, it's raining and all I want to do is just like walk directly to the laboratory, but it's impossible for me. So this is who she would have met if she walked into the laboratory. These are her instructors, graduate students, and professors who have taught her biology during this time period. And one of the things I'm always interested in is looking at the diaries and letters of male scientists at this time period to see how are they thinking about women scientists and their counterparts who were taking classes with him or doing research on vertebrate biology. And what you see is that they either acknowledge them barely or they acknowledge them in ways that are, as you might imagine, relatively pejorative. So this is a letter that Charles Kofoid, who is pictured here on the far left with the mustache and the nice hair, writes actually to his fiancée, Carrie Winter, who was a missionary in Hawaii at the time. And he would sit down every Sunday and write these really long letters to her about his life and what happened. And he says, it's curious to note the attitude of the college and teachers towards the annex, which is the women's college at Radcliffe. It's an annex and so regarded. The boys speak of the museum freaks who inhabit the annex. So this is, I think, a strong argument for, say you want to be a zoologist during this time period or a female physician, you make your way into college, you understand these tacit gender norms, and then your instructors and the people who are teaching you are sort of thinking about your presence there in a kind of freakish, sort of non-normative manner. So I think this explains questions about the history of gender discrimination and sexual harassment in these fields. There are a number of gender stereotypes that continue to persist when it comes to women physicians and women scientists that emerge in the 19th century and continue to be relatively potent. And it's around the sort of paradoxical or oxymoronic association of what it means to be, quote unquote, a women scientist or a woman physician. I think both men and women during this time period were wrestling with this. Science and medicine were so associated with manhood and masculinity and your intellectual capacities that was really hard to kind of figure out what would happen to women, their minds and their bodies, if they entered into these spaces so defined by men. So this comes from a letter that Herbert Spencer Jennings, a relatively famous geneticist, wrote actually to his girlfriend, Mary Louise Burridge. And it's about a woman scientist named Julia Platt. And he's like, Julia Platt's a brilliant scientist in the 1890s. She's really interested in sort of vertebrate development. She's been doing interesting science in Germany, but he found her hard to understand. And he says her whole character, quote, has been warped and made unpleasant by a struggle to do what men do and most women do not. One cannot help realize why it is that so many men hate to see women press into this kind of work, leaving behind what is more peculiar to women as women. So the argument here is that her entering into this space almost denatures her as a woman. There's something threatening both to men and to the female body trying to acquire this kind of technical knowledge. Unless you're someone like Marie Curie, who you see pictured here, and you have 2 Nobel Prizes, it's an unpleasant kind of psychic association of womanhood and this kind of technical expertise. And one of the things I was thinking about in terms of contemporary examples is, maybe some experienced physicians have who identify as women talking to their patients in a clinical space, and the patients sort of saying things like, okay, well, now when I see the real doctor, so you sort of continue to get this cognitive dissonance in terms of women as authorities in science and medicine. One of the big challenges for writing these kinds of histories is trying to find evidence of women in the archive, women physicians and women scientific practitioners. This is because there were few of them. The ones who kind of made it through these educational careers, we need evidence of their existence in terms of their writings or their letters, and it's really hard to find those in archival institutions and repositories that historians can go look at and sift through. So one of the women who I was actually able to find is this woman named Edith Mason Buckingham, who you can see here in her graduation robes. She was the first woman to get a PhD in zoology at Radcliffe in 1910, 1911, and came from a relatively high status Boston Brahmin medical family. So her father was a physician. And she wrote a number of letters to her mother about her experiences being trained. And one of the things that's really interesting about these letters is she describes what it's like being either the only woman or one of two women in almost every room that she's in at this time period. And in this letter in particular, she's writing to her mom about going to an almost all male zoological club meeting, a journal club meeting like you would go to these days. And it was her and her friend Julia Hale. And Julia Hale was up at the board showing her botanical drawings to everyone. And one of the things that happened is that Dr. Parker, who was her professor, asked everyone just to move forward to see what was going on the board. And Julia Hale kind of freaks out. She says, she lost me in the crowd as I moved up. Julia Hale said the men gave her the impression of doing hurdle jumping over the benches. I think this is just so symbolic of that experience of tokenism, or that experience of being the only woman or the only woman of color in a space, which is this almost like the invading army coming forward to identify your differences. And so this is really a hallmark of these experiences of these pioneering generations of women scientists and women physicians, feeling potentially swamped by this invading army of men in these spaces. And Edith Buckingham has a really interesting history of actually moving out of science and more into other fields because of sort of long-standing forms of discrimination. This relates in some ways to the history of medicine, especially the history of professionalization in the medical field. Medicine is slightly different than sort of more classic science, especially more classic zoology, because of the long history of women as medical practitioners. So there's sort of two things that are important to think about this process of professionalization in the history of medicine. Before the 19th century, medicine is really understood by historians of medicine as this world of social medicine. So social medicine being medicine embedded in the home. You can often see this referred to as domestic medicine. So say pre-1888-ish, most women could be considered doctors and healers and nurses in charge of the health and well-being of themselves and their family members and people who live in their towns and villages. So when we think about sort of the history of medicine, we really have to think about women as nurses and healers. And this book, which is called The Accomplished Lady's Delights from 1683, and preserving physic, beautifying, and cookery, illustrates physic, which is the medical sciences, medical practicing, being embedded in the daily routine life of women. So women are at this time, diagnosing diseases, they're treating them using the herbs in their medical garden, they're passing on knowledge from generation to generation about tinctures or forms of treatment or forms of food as preventative health. And one of the really interesting aspects to me of this is that during this time period, there's really a eclectic sense of how to treat yourself medically. So of course you have medicine in the home, but there's also this wider medical marketplace. So say you break a leg, you might need to go to see a bone setter. Maybe you have a long-standing illness, you need to go see someone who's able to let your blood. Only very rarely would you ever go see someone who's university trained, especially in the 17th and early 18th centuries. This, of course, is really important to think about in the context of gender, race, and geography. One important aspect of this, and I'll talk about this a little bit more, is that enslaved women in the antebellum South in the 19th century, many of them had sort of amazing talents as healers, as doctoresses, and as nurses, were both sort of treated and worked for preventative health measures for their enslaved community members, but were coerced into doing that for white slaveholders at the same time. So some of the histories of the professionalization of medicine don't always take into account the way that sort of race intersects with coercive healthcare measures, especially in, say, the American South in the 19th century. A classic example of social medicine that relates to gender is social childbirth. This idea of having your child at home or having your child in a community of women, seen sort of through your labor and delivery with a local midwife. That experience of embeddedness really changes in the late part of the 19th century related to this problem of professionalization. So if social medicine really dominates the experience of medicine until, say, the midpoint of the 1800s, scientific medicine starts to change the experience of medical expertise, who's thought of as a medical practitioner, sites of medical care. So you see the shift from the home to the hospital as a site of medical care, and modes of medical knowledge. So this major change from empirical knowledge passed on from generation to generation, largely through lineages of women, to more abstract, say, theoretical knowledge that you you would get at a university. So some of the hallmarks of scientific medicine that really shape the professional field of medicine and continue to shape it today are a number of gatekeeping measures. So institutions like the American Medical Association arguing that to be a medical practitioner, you have to go through a certain form of education, undergraduate education, higher education, residencies in order to be accredited as a physician. In some ways, that's really great. It standardizes medicine, it sort of transforms it into its modern space and modern era. And other ways, it's really challenging because you can imagine how those gatekeeping functions get to start being set up if the people who are making these decisions are largely the people who I showed in these earlier slides, communities of white men. So in the 19th century, the conversations that we like to have about the professionalization of medicine is the entrance of the first accredited female medical physician. So here you can think about the Blackwells or Rebecca Lee Crumpler from the New England Female College of Medicine. We can also think about the importance of scientific medicine in terms of these really powerful tools coming from bacteriology, tools that allow us to understand germ theories of disease, to really identify sort of treatments and therapeutics in ways that are evidence-based and incredibly powerful in terms of treating patients. One of the things that historians of women in medicine often point to during this period is not only the rise, sort of the expansion of hospital systems as primary points in care, but the lack of expanding opportunities for female physicians. So there's a statistic, which maybe you've heard a little about, that by 1920, 5 to 6% of doctors are women, a percentage that is relatively unchanged into the 1970s. So you get this rise, you have this sort of potential that starts in the 1840s with the Blackwells, women sort of moving through medical colleges, especially women's medical colleges, looking for careers as physicians, and then it plateaus in the 1920s. And this is really called the problem or paradox of professionalization in the history of women in medicine. Why is this? There's a number of reasons why we get this sort of plateauing point that doesn't change until the 1970s. One is that most of these women until 1920 were educated at women's medical colleges. These colleges tend to shut their doors in the 1920s because there's a preference on the part of medical colleges and medical students for coeducational instruction. And what happens is the women's medical colleges start to shut down. Coeducational instruction has more of a quota in terms of women who are able to move through those spaces. So we get this, how great is it that men and women can be educated together? How can we see this as a major challenge or bottleneck for women making it through these medical careers? So that's one of the things that happens. One of the other things that starts to happen is through the standardization of medicine, you need additional requirements for being a medical practitioner, like an internship year and a residency. So say you make it through medical school, which many women do, it's very hard to then find a residency or an internship, especially if you're a woman of color in a hospital in sort of the northern part of the United States. It's really hard to get that extra year of training because of sort of medical sexism and medical racism. So we get this, again, this plateauing point where women sort of make it through their medical careers, but don't get to the next stage. We can think about this in terms of the experience of childbirth and its shift from social childbirth to scientific childbirth in a number of ways. I always think this graph is like relatively stunning. This comes from the work of Judith Walser-Levitt, who wrote this book, Brought to Bed, which you can see in the the sort of left right-hand corner of the screen. What it illustrates is changing patterns of who is attending childbirth and where that birthing experience is, say from the beginning of time-ish to around 1950. And there are two inflection points that are really important for us to understand. The first one is in 1900. So in 1900, for the first time, you have more childbirth sort of opportunities that are overseen by physicians than midwives. This is like this inflection point in 1900 that changes, the previous 200 years, 300 years of experience in North America and shifts it suddenly from midwife-based care to hospital to physician-based care. The second inflection point here that's really important is in 1938. You can see this with the dotted lines. And this is this shift from having your birth in a hospital versus having your birth at home. So for the first time, we have more births in a hospital than we have ever before in the previous several hundred years. And I think this is really, really important for us understanding the experience of childbirth and its transition point in the 20th century, and our understanding of how expertise and sites of care change in the long history of medicine. One interesting point that actually Laurel Ulrich makes, and she has this great book called A Midwife's Tale, maybe some of you have read it, it's about sort of midwifery experience in Maine in the late 19th and early 20th century, is that in terms of patient outcomes, this shift of childbirth to physicians and to hospitals reduces patient outcomes. So it increases infant mortality and maternal mortality rates until the introduction of sulfa drugs during World War II. And these are one of the things that's really interesting to me as a historian of medicine. Why, if the patient outcomes were worse, did women and their families choose to have them be attended to by physicians at the time? This time it's almost completely male physicians, just to clarify, and in hospitals. And I think the argument here is that there was a powerful kind of cultural shift in expectations around what medicine meant. And many of these women argue that we want the most modern forms of medical care. Childbirth is dangerous and scary. We want the assurance that you could have additional interventions, so forceps, sort of surgical interventions, anesthetic interventions, and there was a higher status of male physicians at the bedside during this time period. So all of those things contribute to why women might want to elect to see a male midwife as opposed to, or a male physician as opposed to a female midwife, but it really leads to these sort of more negative patient outcomes well into the 1930s and early 1940s. So this to me relates to lots of research that you're maybe familiar with that continues to come out that has been sort of spun in more general ways in science media and in medical media. These questions about what is the difference of patient experiences and patient outcomes in relationship to sort of the sex identification of physicians. And these are just two very recent studies. The first one, comparison of hospital mortality and readmission rates for Medicare patients treated by male versus female physicians, suggests that there is a small, there is a small improvement in patient outcomes for female physicians treating patients. Again, the mechanism is a little bit, it's a little hard to understand, but there is this idea for some reason that women have better outcomes in terms of the patients that they're treating. And then the second one that came out relatively recently is about the relationship between the sex of surgeons and the sex of their patients. So this idea that actually the worst outcomes tend to happen when male surgeons are treating female patients. Again, all of these studies tend to assume binaristic notions of sex, so we don't necessarily get the non-binaristic notions of sex. And there are unclear mechanisms about exactly how this is happening, but it does relate to this longer history of how do we think about gender and caregiving? How do we understand patient outcomes? And in what ways has professionalization impacted the roles that women have had in the medical field, especially in certain medical subspecialties? So I was saying earlier, I have a number of students who I've taught in history of women in medicine courses who go on to medical school or PA school or nursing school or school of social work. And I often hear from them once they match or once they go through their residency process. And it's really interesting for them to talk a little bit about the relationship between sort of subspecialties and residencies and questions of gender. So I have a couple of students who said, I really was like surprised that in surgery, it's still like a lot of men. So there still are some of these longstanding questions about expertise and specialization in gender. Okay, so that's a very brief history of the role of women in science, the role of women in medicine, and how professionalization raises certain hurdles for men and women, and certain hurdles that sort of turn gender into a difficult process. So the second thing I briefly want to talk about, and feel free to cut me off at any time, is how this relates to knowledge about the female body. So we can sort of start with this image of women in medical college playing with anatomical skeletons and think a little bit about how the history of anatomy relates to these sort of gendered notions of the male and female body. So this comes from the Enlightenment period. So one of the really interesting aspects of thinking about the history of medicine is where did we get notions of the gendered body, and how did historical ideas about men and women layer into biomedical understandings of structures? So when it comes to male and female anatomy, what is really interesting about this is even early on in anatomical sketches of men and women, what you start to see are cultural connotations of femininity and masculinity. masculinity inscribed into these biological objects. So on the left here, we have the skeleton of a female, and on the right, we have the skeleton of a male. And historians have pointed out that actually this female skeleton is out of proportion. Its hips are too large, its diaphragm and its ribcage is too narrow, and its head is actually too small compared to relatively more proportional human examples. And the argument here is that actually the artist, Marita Arkenville, who's putting this together, wanted to illustrate ideal forms of femininity in this kind of medicalization of the female body. So again, we have this notion of sort of wide hip-bearing pelvises, sort of narrow ribs, either due to corsetry or due to the fashion at the time, illustrating the ideal female form. And this gets layered onto notions of humans and their relationship to other forms of non-human animals. So in these atlases of male and female skeletons from the 18th century, what you start to see is female skeletons associated with ostriches, sort of like birds of fancy, like it's a bird that can fly. So like, what does that mean? And male skeletons associated with horses. So this like idea of like the most important thing or sort of mechanism for transport during this period. And the other thing that you start to see is you see female skeletons that are slightly disproportionate because they're seen to be analogous to or more analogous to children than they are to males of their species of their same age. So these are some of the ways in which gender bias makes it into medical descriptions of female skeletons from very, very early on. These notions of gender and say what we call scientific sexism intersect with notions of scientific racism during this period, not only to structure sexual difference, but also to structure racial difference and thinking about biology. So this comes from Louis Agassiz, who actually founded the Museum of Comparative Zoology, of the image of the bug people I showed you at the very beginning of this talk. What he argued for was this theory of polygenesis. So people of different races were specially created in different areas in the world. And that what we can do is we can understand these in a sort of hierarchy for, sort of notions of European white men at the top and notions of sort of quote unquote primitive civilizations at the bottom. So ideas of scientific racism integrate with ideas of scientific sexism in a number of different ways to disadvantage women of color in particular. And we can see this in terms of the long history of medical mistreatment of Black women and Black men through the 20th century and into the 21st century in the American history of medicine. The 19th century example of this is Hottentot Venus. So she was a woman who was trafficked from South Africa to Britain and later brought to Paris. In Paris, she was examined by Georges Cuvier, who is the head, the father of modern biology, to try to understand her relationship to this hierarchy, this sort of racialized hierarchy. And one of the important lessons here is that there is sort of a long history of white supremacy embedded in the production of medical knowledge about the body. And there's a long history of questions of consent in terms of who has access to be able to advocate for being subjects or objects of medical knowledge. I often have students read a little bit about the history of gynecology in my classes, and maybe some of you have heard of J. Marion Sims and his history in the American South as a gynecological experimenter. These are images on the right of Anarcha, Lucy, and Betsy. So these were three enslaved women that he non-consensually treated for a number of years in the 1840s and 1850s. And one of the things that I was really happy to see is this is a sort of a beautiful sculptural work honoring the legacy of Anarcha, Lucy, and Betsy by the artist Michelle Browder. And I think it illustrates the role that women, especially the role that patients play in the production of medical knowledge in ways that have really been obscured until, say, the past 10 or 20 years due to the work of historians and activists and artists. I don't know how much time I have, but there are two sort of other aspects related to how knowledge about the female body takes on cultural stereotypes related to sexism and racism to reproduce these stereotypes in the language of science and medicine. I think this is one of the things that we have to guard against the most in terms of training our students and thinking about the impact of knowledge the impact of scientific and medical knowledge. One is it comes from the world of evolutionary thinking and evolutionary biology. So this is very potent in the late 19th century. This comes from the work of Charles Darwin, who wrote The Origin of Species. And one of the things that he's trying to understand, and many scientists are trying to understand, is the difference between males and females in the context of sexual selection. And so what he tries to say is he says, okay, I recognize that there are differences between males and females in the animal world. So here's an excerpt from his book. He says, no one will dispute that the bull differs in disposition from the cow. And he's trying to think about, okay, these are evolutionary differences in the non-human animal world. How does this relate to human differences? And he says, actually relates pretty one-to-one. Just as there's sex differences in the animal world, there are sex differences in the human world. And evolutionary theory helps us understand that these things function sort of together and in tandem. So he says in this particular excerpt, woman seems to differ from man in mental disposition. The chief distinction in the intellectual powers of the two sexes is shown by a man attaining to a higher eminence, and whatever he takes up, the woman can attain. So this is one of many examples of how scientists sort of construct scientific theories based on sex difference to just reify sex differences in the human world. Darwin is using examples from the animal world. He's also using examples from his own Victorian marriage to another woman to argue for the way that evolutionary theory has selected differences for men and women in the wider world. This is a very classic example in the world of the history of biology, this idea that sort of social expectations about men and women carry into scientific ideas about them. And then those scientific ideas, there's a feedback loop, explain away, quote unquote, natural differences between men and women. But the most potent one in the history of medicine comes from the physiological knowledge in the late 19th and early 20th century. So again, we have gender stereotypes about men and women that become embedded into medical notions about the male and female body. That have a similar kind of feedback loop. So this comes from the work, maybe you've also heard of this person, of Edward Clark, who is a Harvard medical practitioner. He becomes really concerned in the late 19th and early 19th and early 20th century, with a number of cases of young women who are coming to his office who have gone to college or gone to medical school and who have physically degenerated in consequence. So this is a period in which physiological knowledge is based on this closed energy system. So the idea is that all humans have a limited amount of energy. So if you're taxing one area of your body, for example, your brain, you're going to remove your sort of energetic juices from another area. So for example, your reproductive organs. And so one of the worries that he as a medical practitioner and many other medical practitioners had during this period is what happens to women when they enter into medicine in the first place, or they enter into other forms of higher education. And so this is an example of one of his patients, Mrs. D, who goes to college in a good physical condition, but because of excessive study, she's sort of like taking all of the vital juices from her reproductive organs and putting them in her brain. And it says the stream of vital and constructive forces evolved within her was turned steadily to the brain and away from the ovaries. So it's sort of damaging the reproductive futures of herself and any of her fellow sort of schoolmates. These questions are directly related to women studying medicine. So this is a very classic image on the right of depictions of women in medicine at the time. As you can see, this is a lady doctor. This is a caricature of Elizabeth Garrett Anderson. And what has happened is she studied so much that her energetic juices have moved away from her reproductive organs into her brain. So you can kind of see in visual form the consequence of those kinds of actions. I will say both men and women were struck by physiological discontent during this time period. And gender not only played a role in diagnosis, but it also played a role in treatment. So if women were diagnosed with some sort of physiological discomfort, they were often prescribed rest cure, where you stay in your room, you close all the doors, you have a diet of massage and eating rich and fatty foods. If a man happened to be diagnosed with a form of nervous disorder like neurasthenia, the idea there is to go and sort of retain your manhood out in the great outdoors. So here, like Teddy Roosevelt, find your gun and your buckskin suit and go to South Dakota and hunt some deer. Like that would be the kind of therapeutic treatment there. This continues to play a role in reproductive knowledges today. So Emily Martin, who's an anthropologist, has this very classic article who talks about these gendered notions of scientific theories of male and female sex differences that we can see in evolutionary theory, that we can see in physiological theories of the human body, make its way into biomedical explanations of fertilization. And one of the things that is really important to understand is how these narratives continue to structure patient care and patient outcomes. onto the 20th and 21st centuries. So you both have academics who are interested in thinking about these sort of scientific forms of sexism and scientific forms of racism that make it into scientific and medical theories that impact experiences of training and patient care, like Deirdre Cooper Owens' book Medical Bondage, and Barbara Gurr, who works on Native American women and their experiences of healthcare on Native reservations, and then more popular takes on that. So Caroline Perez's book Invisible Women has a couple chapters around drugs and misdiagnosis of women. And of course, Maya Dewsbury's Doing Harm is a good, more general introduction to this. Looking towards the future, let me just make sure there's nothing going on in the chat. Looking towards the future, there are a couple of things that we can say in terms of changes about the history of women and in science and medicine and medical treatments of the female body. One is that there's this moment in the 1970s where things really start to change. And to me, this speaks to the work of collective activism and the work of legal challenges on the part of Title IX, and also sort of more local sort of legal challenges to access to forms of equitable education, equitable hiring, and equitable treatment in the workplace. And here, this is in the context of the academic workplace or the hospital-based workplace. And so we really start to see a rise in the entrance of women into medical spaces in the 1970s as a consequence of the women's movement, the civil rights movement, and a rising awareness that many of the forms of gender-based harassment and sexual harassment that individual women face were actually collective. So there are a bunch of new terms that start to come to light in the 1970s and 1980s, where women identify that their individual experiences of having a hostile or chilly climate in a hospital, in academic medicine or in academic science are actually shared. And that really becomes important for retelling the story of discrimination in medicine, not as a story of I myself am not good enough, but a story as there's a structure that I am experiencing that has a collective problem, and it takes collective action to try to push back against these historical forms of discrimination and seek a better future. So some of the work in the history of medicine that is really important is Frances Connolly coming out. She's a neuroscientist and a neurosurgeon at Stanford, and saying that I've been really successful and my career has been impaired by long-term forms of sexual harassment and discrimination. I was going to talk a little bit about questions of representation in STEM, but I want to highlight two things as I close. One is that there's this great graphic from 2019 that the majority of medical students are now women. This is something that has been a long time coming, and maybe you've experienced in your own life. And the second thing that I want to illustrate is that there are lots of different efforts for thinking about equity, inclusion, and justice in science and medicine. And one of the things that I often talk about with my students is the role that pop culture plays in reshaping expectations of who fits into science and medicine and technology and what that might be. And interestingly, there's been a lot of academic research on the importance of Black Panther, and especially Shuri from Black Panther, who is a sort of this amazing technologist, in creating sort of an image of the possibility for young girls, especially young Black girls, to pursue careers in STEM. So there are many different ways we can tackle these problems, but for some reason, pop culture is another space that we can think about as being important. So I will conclude there. I would love to talk about anything you'd like to talk about. And I really appreciate the time that you take to think a little bit about this history of women in medicine, this history of the relationship between representation and knowledge production in medical fields. So I'll end there.
Wow, thank you so much, Dr. Tonn, for joining us today and sharing that incredible presentation. And I've learned so much, and I'm sure everyone else in the room has as well. So thank you for joining us in honor, especially for Women's History Month, and closing it out in this way. So now I'm just going to open it up for Q&A. So like Devin said in the chat, please feel free to write your question in the chat or raise your hand and unmute yourself. I guess we can kick it off with Sandy.
Hi, that was spectacular. I thought I knew a lot, and I gained a tremendous historical perspective. Just wonderful. Wanted to add, I know that right now for appropriate reasons, we are concentrating on issues of color, but if you can trace the same thing for Jewish scientists and Jewish physicians. Until 1950s, there was a quota in all of the medical schools for Jewish students. And for example, Columbia acknowledged that they had in their medical school quota for 8% of students this is in New York, because that was the national average. And until Einstein opened up and opened it without quotas of any sort, did we see a difference? And up there in parallel, women became full professors immediately. They left from research associate positions in other universities and were hired there. So this kind of openness is critical. I'm going to do one other thing on a soapbox here. Dr. Sim's statue was opposite the New York Academy of Medicine, and our scientists and physicians were essential in having it taken down a couple of years ago. And so really proud of the activism of Sinai on that. I also wanted to mention, I'm sorry, I'm giving my own little spiel.
No, please. Yeah.
And please, anybody else jump in, but Mary Jacoby, who was the wife of Abraham Jacoby, they set up the first pediatric clinic any place and the first department of pediatrics in a hospital. She received a degree. Well, she did some of her study up at one of the Harvard hospitals and got a degree for got an award for evidence-based medicine, which was the Osler Award. So, and this was in the late 1800s. So paralleling some of what you were saying. But one thing I wanted to ask you about was in the 70s, we saw women really coming into their own in other ways, like Our Bodies, Ourselves as a handbook for women. And I wonder how that fits into your version of women's knowledge about their own bodies.
Yes. Yeah. I mean, these are great questions. It's really interesting to hear about Jewish sort of scientists and quotas around there. And I think, you sort of see that for women in women's colleges. Mary Putnam Jacoby is really interesting because she actually writes a rebuttal to Edward Clark's book about sex and education. One of Edward Clark's arguments is that actually what happens when women go into higher education is that their menstrual cycles get all like wacky, and that sort of, creates degeneration of their bodies and minds in the first place. And Mary Putnam Jacoby is like, okay, well, let's do some like actual research on this. So she surveys women in women's colleges and produces an evidence-based account of the fact that actually their menstrual cycles don't change as they enter into medicine. And that ends up winning an award by a Harvard boarded group of individuals in the late part of the 19th century. So she's like at the forefront of saying, let's use science to think about science. In terms of your question about the women's movement and Our Bodies, Ourselves, I mean, Our Bodies, Ourselves is so important in the 1970s for women, not only compiling it and putting it together. So for those of you who don't know, Our Bodies, Ourselves is this, it's basically a handbook for women that teaches them about their bodies. So it's about women's biology, it's about childbirth. It's originally published in 1969, 1970, 1971. It goes through a number of different editions. And in oral histories of sort of women who have access to this handbook in the 70s and 80s, is hugely powerful. Most of these women are only going to see male physicians, especially male OB-GYNs. And it's, for many of them, an incredibly traumatic experience, sort of having either issues with fertility or issues with labor and delivery or questions about sexuality and going into an almost entirely male medical sphere and not being listened to in terms of the experiences that they're having, the pain that they're feeling, and the concerns that they have about their body. And so Our Bodies, Ourselves it turns into this like how-to guide of how do you understand yourself? How does equipping yourself with basic knowledge about, your body actually empower you to make choices about your patient care opportunities? And it's this collective consciousness raising moment for many women who have access to this. So Sandra, it's hugely important for especially women who are part of the women's movement in New England, who tend to be white, middle class and upper class women. It gets adapted over time to expand and think more about the experiences of women of color, the experiences of gay women, lesbians, people who are interested in reproductive technologies to complete their family. So it changes with the times. And it's a really good indicator for some of the challenges that the women's movement has in the 70s for inclusion and how they try to address that into the 80s and 90s. So yeah, that's a good question.
I think we have time for one more question. If anyone has any comments or questions that they'd like to share with Dr. Tonn.
Hi.
ahead.
I just wanted to thank you for such a wonderful presentation. As an OBGYN, I learned from you, and it was really great. You know, the history of midwives within OBGYN is something that's so interesting, and really, as you were highlighting, the beginning of the use of forceps and other modalities has really changed that trajectory. I was wondering if you could just highlight really quickly what you think we can do for our trainees, for our medical students to embed this knowledge as we're moving forward, because I think that's so critical. And thank you again for a great presentation.
Yes, thank you, Dr. Stern. I mean, this is a good question. I mean, I kind of think two things in terms of training and how, I mean, my argument is history is a really good lens for thinking about how the field has been structured in the past and thinking about potential ways that the field can change in the future. For people who are interested in, say, the history of obstetrics and gynecology, I would say read Deirdre Cooper Owens' book, Medical Bondage. She gives you a really important long take on how notions of gender and notions of race are tied into medical advances in gynecology, which are important for improving patient outcomes, but have to be reconciled with in terms of thinking about how that knowledge is produced in the bodies of enslaved women. So I think, you know, and having some form of history that allows for interpretation and allows for understanding the structure of medicine is really important. I think the other thing that is really helpful, and some of the things that I do in my class, is I invite, and this is probably part of your training and your students' training, I invite people to come talk about their experiences, or I require students as part of all of my courses to do 1 to 2 oral histories with a family member, with say any woman who has given birth or wanted to give birth, and talk to them about what was that experience like? What were some of your concerns? Tell me more about that. I think having that experience of informally discussing a topic like this raises people's awareness of how complicated it is, how emotional it is, and how people's individual experiences don't always plug into the wider world of medicine easily. So those are 2 things I would say: read Deirdre Cooper Owens' book and have some relatively informal ways students can talk about other people and their experiences.
Thank you.
Thank you so much, Dr. Tonn, for joining us. And thank you everyone for joining us for this event. I just want to encourage everyone to stay connected to our Office of Gender Equity, sign up for our newsletter, follow us on Twitter, check out our website. We're going to be continuing the Amplifying Equity Series this year. So if you sign up for our newsletter, you'll be able to stay connected on when our next event will be. So thank you all.
Thank you. Happy Women's History Month, which should be every month, but yeah.
It will
Thank you
be.
so much. This was great.
Good.
Thank you. This was just absolutely great.